Hello students, I am Dr. K. Selvan, Associate Professor, Department of Periodontology, Vinayaka Mission Sankaracharya Dental College, Vinayaka Mission Research Foundation, deemed to be university. Today we are going to discuss on resective osseous surgery. Before going on to this topic, you need to know what you are going to gain at the end of this session. First thing, the essay what you can expect from this chapter is the entire text, that is the resective osseous surgery. Then the other short notes can be osteoplasty versus osteectomy, what is a physiological bone contouring, what are the possible architectures of the bone, that is positive architecture, negative architecture, flat architecture, as well as the vertical grooving and radicular blending. Now coming on to the contents, first we will see a gist of what is a resective osseous surgery. Then we will move on to what are the normal bony structures and what can be the defects that can be caused by the periodontal disease in these bony structures. Next, how you can determine the bony defects. There are four methods. One is the clinical method, the next one is the radiographic method, the third one is the surgical re-entry method. Next is the objectives and rationales you can see. Next, when you should do this resective osseous surgery, then when you should not do this resective osseous surgery, that is the indications and contraindications. Next, how you can do this resective osseous surgery, as well as you know, there are 4 steps in doing this resective osseous surgery. Next, in which situation you should go for this resective osseous surgery. In all the situations we cannot do this resective osseous surgery. In few cases we will be doing the addition of the bony grafts. In few techniques we will be reducing the bony structures. Then the last point will be the healing followed by the resective osseous surgery. Now coming on to the introduction, we all know that periodontal disease is caused by the plaque structure, right? Once this plaque is accumulated, what happens is that first the gingiva is going to be inflamed. This condition is called as the gingivitis. Okay, if it is left untreated, what happens is that this inflammation is going to affect the underlying connective structures of the gingiva. Then what happens is that even then, if you are leaving untreated, then it will affect the bony structures. Then there are going to be 2 types of defect, as you know. One is the horizontal defect, the next one is the vertical bony defect. Okay, next, why we are going to do this resective osseous surgery? The first thing is that to get a physiological architecture of the bone with a shallow gingival sulcus, that is of 2 to 3 mm. Next, to produce an alteration in the bony profile, why? To provide a sound base for the gingiva to heal, okay, and to be maintained. Here you can see there are 2 types of surgeries. One is the additive osseous surgery, where you can place a bone graft. Next one is the resective osseous surgery, where you are going to grind the bone. So coming on to the definition, what is a resective osseous surgery? It is nothing but we are going to do some changes in the alveolar bone. Why we are going to do some changes? Because of the deformities which was caused by the periodontal diseases or other conditions such as exostosis or other disturbances like tooth supra-eruption. Okay, this is the definition. Resective osseous surgery may be defined as the procedure by which changes in the alveolar bone can be accomplished. Why? To get rid of the deformities which was induced by the periodontal disease process or other related factors such as the exostosis and tooth supra-eruption. Now, as I said earlier, one is the additive, where we are going to place the bone graft. Next one is the resective, where we are going to remove some of the alveolar bone. So coming on to the terminologies, you must know these 2 terminologies basically. One is the osteoplasty, where you are not going to remove any part of the bone, you are just going to reshape the alveolar bone. The next one is the osteectomy. Here you are going to remove a part of the bone or the bone itself, even it may also support the tooth. Now coming on to the other terminologies, this is very important and interesting. One is the positive terminology, negative terminology and the flat architecture. So before going to these terminologies, you should know what is the interdental bone and what is the radicular bone. Here in this image you can see this is the interdental bone and here is the radicular bone. Okay. Usually in the normal conditions, the interdental bone will be more coronal when compared to the radicular bone. This is often we call it as the positive architecture. In case of negative architecture, it will be the interdental bone will be apical to the radicular bone. In the flat architecture, both will be at the same height. So the interdental bone, as I said earlier, it is consistently more coronal in position than the labial or the lingual palatal bone. The marginal bone, it will be similar interdental height with gradual slopes between the interdental peaks. Now coming on to the rationale, that is why we are going to do this resective osseous surgery. There are few important basic points which you need to know. One is to bring a positive architecture, that is you need to provide the interdental bone a more coronal to the radicular bone. Next one is the alveolar crust, it should be parallel to the cemento-enamel junction of the tooth structure. Next, the alveolar margin should be thin. If it is thick, then again the periodontal disease is going to progress. Next, festooned bone in both the buccolingual contour. Next, to provide a harmonious contour in the level and the shape of the bone. Now coming on to the objectives. So by doing this resective osseous surgery, what you are going to gain? First is primarily to remove the osseous deformities and create a physiological contour of gingiva. What is the physiological contour? It is nothing but a functioning level of the gingiva. Okay. Next is the elimination of the periodontal pocket. By doing this, you can eliminate the periodontal pocket, and by doing this, you can give a primary closure of the flap margins. And for example, if you are going to restore a tooth and if there is no enough crown length, you can go for resective osseous surgery and provide enough crown length for placing the restoration. Now coming on to indications, where all we can do this resective osseous surgery. First, when there are inconsistent bony margins. Next, if there is a reverse architecture, there is nothing but if the radicular bone is more coronal to the interdental bone. One wall defect, in the sense only one wall will be present. In that case, we cannot go for additive osseous surgery. So therefore, we have to plan for a resective osseous surgery. Next is the buttressing bone formation. Next is the ledges and plateau. Ledges is nothing but an abnormal elevation of the bone at the marginal level. Next is the shallow craters, furcation defects. As I said, the crown lengthening for the restorative dentistry. Now coming on to the contraindications, that is where you should not do this resective osseous surgery. One is if there is already an extensive bone loss, if you are going to remove more amount of bone, then the tooth is going to be mobile. So in those cases, it is contraindicated. Next is the high caries activity. For example, if you are going to remove the alveolar bone, there is going to be recession, some amount of recession. So if already the patient has a high caries activity, then it is going to affect his tooth. So in those conditions, you should not do. Next is existing mobility. If a tooth is already in a mobile state, if you are going to remove some amount of bone there, then the mobility will be increased. Next, in the aesthetic zone, for example, in the upper anteriors and the lower anteriors, if you are going to remove the bone, then there is going to be recession which affects the aesthetics of the patient. Now coming on to the advantages and disadvantages. First is the predictability. We can easily predict the prognosis of the tooth. Next is the complete elimination of the periodontal pocket. We are going to remove the pocket anyhow. Then ideal bone form we can obtain. Now the disadvantages will be the loss of valuable supporting bone, the gingival recession, as I said earlier, there can be sensitivity, it is going to affect the aesthetics. If you are going to remove the bone, it is going to result in the mobility of the tooth. Now as I said earlier, the examination consists of 4 stages. One is the clinical sign, by seeing the tooth itself we can tell. Okay. Next, by checking using the periodontal probing. The third one is going for investigation, that is the radiograph. The last one will be the surgical exploration of the particular site. So coming on to the first sign, that is the clinical signs, you are going to see there is an inflammation of the gingiva with deposits, bleeding, swelling, etc. There is going to be increased flow of gingival clavicular fluid, bleeding and exudations. The next one is periodontal probing. There is going to be a walking method of probing. The pocket depth will be greater than that of the normal gingival sulcus. That is, the normal gingival sulcus is going to be 2 or 3 mm. So if it exceeds more than 3 mm, we call this as a periodontal pocket. The location of the base of the pocket relative to mucosal junction and attachment level on the adjacent teeth, and there is going to be presence of the furcation there. So now coming on to transgingival probing, there are 2 methods. One is the vertical transgingival probing, the next one is the horizontal transgingival probing. In both the cases, we have to give the LA, then we are going to probe until the probe hits the bone level. The next one is the radiographic method. This is only a 2D method where we cannot usually visualize the buccal or the lingual bone, but we can see the defect in the interdental areas or in the furcation areas to the minimum. This is the confirmatory thing to see whether there is a bone loss or not. This is the direct observation during the flap surgery, and it is the only definitive method for determining the architecture of the bony deformity, because the radiograph is going to be a 2D method. Now coming on to the procedure for resective osseous surgery. First, we should know what all armamentarium that is required for this resective osseous surgery. One is the Friedman's rongeurs, okay, which is going to remove the alveolar bone by cutting the alveolar bone. Next, in order to trim or cut the alveolar bone, we need carbide round burrs and also the diamond burrs. Other than this, we need the interproximal files, okay, to do the osteoplasty procedures, and other files like back action chisel file and the Oxenbein chisel file to smoothen the bony contours. Now coming on the other equipment that is known as the piezoelectric surgical device, there are two modes usually. Okay, one is to cut the bone, the next one is to work on the root surfaces. So this is the electronic device which generates the ultrasonic micro vibrations at a variable frequency. It won't cut the soft tissue, it is going to operate only on the hard tissue, which is the safest part of this equipment. Now coming on to the four techniques, okay, by which we are going to do this resective osseous surgery. One is the vertical grooving, the next one is the radicular blending, that is you are going to blend the vertical grooving which you are going to provide. The next one is the flattening of the interproximal bone. The last one will be the gradualizing the marginal bone. Okay, as you see in this, the first two techniques will come under the osteoplasty procedures. They are purely osteoplastic procedures where you are not going to remove any part of the bone. The third and the fourth one, it comes under the ostectomy procedures. In a condition, not all the steps are necessary, but the sequencing this stage is very essential. Why? Because to minimize the removal of the bone and accelerate the procedure. For this procedure, we can combine both the hand instruments as well as the rotary instruments. Coming on to the first technique, which is known as the vertical grooving. Here you are going to make a depth of around 1 to 2 mm evenly on all the surfaces. This is to eliminate the unwanted removal of the bone at a particular site. It defines the general thickness and subsequent form of alveolar housing and to reduce the thickness of the alveolar housing. It is performed with the rotary instruments such as the round carbide burrs as well as the diamond burrs. So the advantages will be, it is most apparent with thick bony margins and shallow craters, area which require minimum ostectomy and maximum osteoplasty, because this is an osteoplasty procedure, right, as I told earlier. Now the contraindications, when the bone is at a close proximity to the root surface, we cannot go for this vertical grooving procedure. Also, if the thin bony plates are there, we cannot do this grooving, because if we do this grooving, it is going to expose the root surfaces. Now coming on to the radicular blending, this is nothing but an extension of the vertical grooving, that is you are going to connect the radicular grooving. It gradualizes the bone over the entire radicular surface. It is going to smooth and blend the surface for good flap adaptation. It is not needed if minor vertical grooving or radicular bone thin and if it is fenestrated. Similarly, as I told earlier, this vertical grooving and radicular blending both are purely osteoplastic techniques. Next is the shallow craters, the thick osseous ledges on the radicular surfaces. If there is any grade 1 or grade 2 furcation defects, we can go for the ostectomy procedures. Okay. This grade 1 is nothing but an incipient lesion, grade 2 is nothing but the cul-de-sac procedure. Now coming on to the flattening of the interproximal bone, this is the third method. The indications are, when the interproximal bone levels vary horizontally, okay, we are going to flatten the interproximal bone. It is nothing but removing the bone till the base of the defect. If there is one wall defect, that is the one wall is present in the interdental area, we have to remove this until the base of the defect to provide a stable bone for the gingiva to support. Next is limitation, where we cannot do this. If the lesion is advanced, we cannot remove the bone there because it is going to result in mobility of the tooth, okay, and unnecessary gingival recession. Next is the crater formation. Next is the flat interproximal defect. If the interproximal defect is going to be a flat, there is no need for the removal of the bone there. The next one is the gradualizing the marginal bone. So the bone removal necessary to provide a sound regular base for the gingival tissue to follow. Okay. But if you are going to fail to remove small bony discrepancies, especially on the line angles of the tooth, it is going to result in a irregular bony spicules, and this spicule is called as the widow's peaks. So these are the four techniques by which we can do the resective osseous surgery. Now we can see what are the specific situations where we will apply this resective osseous surgery. One is the management of the craters. We all know that crater is a two-wall defect, that is there is going to be a labial or buccal wall and a lingual wall. The mesial and the distal wall is going to be absent. So the defect is nothing but it will be like a concavity. The crater can be shallow, moderate and deep. The management is of different types. If the crater is shallow or moderate, we can go for resection, that is, we can remove the part of the bone. If the crater is going to be deeper, we can go for regeneration, that is, we can place the bone graft over there. We will see how we are going to do resection, that is, in the case of shallow or the moderate osseous craters. So, ramping is nothing but removing only one wall of the osseous crater, because if we are going to remove both these walls, there is going to be more amount of attachment loss to the tooth. So, the tooth is going to be mobile. In order to prevent this, we are going to do ramping, that is nothing but we are going to remove only one portion of the wall. So, we are going to make it cleansable for the patient and he can easily maintain that area. Now, the next one is the hemiseptal defect. We all know that hemiseptal is nothing but a one wall defect, that is, one wall is going to be present in the interdental area where the patient he feels very difficult to manage it. So, we are going to remove this one wall defect, otherwise the hemiseptal defect, so that the patient can easily maintain that area. Next, if there is going to be inconsistent bony margins, we have to remove the bone by resective osseous surgery. That is, if there is a thin bone frequently associated with inconsistent margins. As I said earlier, if there is a widow's peak, we have to remove it. Corrected by reducing the marginal bone level on adjacent teeth. If we are going to correct the bone level on the adjacent teeth, it is going to remove the widow's peak. If the ideal architecture is not possible, bone margin with a gradual rise and fall can be made at that particular site. The hand instruments what we can use can be curettes and the oxenbein chisels. Now, the correction of the thick bony ledges. In the posterior areas, what the defect can be seen is that in the maxilla, exocytosis can be there, bony protuberances or the buttressing bone formations can be there. In the mandible, there can be bulging at the external oblique ridge. If we are not going to treat this, it is going to create a gingival step, which we do not want. So, we can create a proper bone by doing the resective osseous surgery, which provides a sound base for the gingiva to adapt. Next is the edentulous ridges. Here you can see there is a abnormal bony structure in the edentulous area. So, we can correct this particular site by removing this entire bony level till the base of the defect. Thereby, we can properly adapt the flap. The next one is that after doing this resective osseous surgery, what is going to happen? How the site is going to heal, right? This is very important. It can be asked as a short note as well. First is that within a day, there is going to be a blood clot formation. Next, within 1 to 7 days, there is going to be a formation of the epithelium. Epithelium is going to heal, granulation tissue is going to form. Then, within 1 to 4 weeks, connective tissue growth, formation, healing and collagen formation is going to happen. Bone remodeling and the establishment of the physiological architecture, it is going to take place around 1 to 6 months. So, the healing mainly occurs by long junctional epithelium attachment with limited to regeneration. So, this is all about resective osseous surgery. Thank you all.